Okay, we have some spaces. What does it mean, spaces? It's the cavity between some organs. You remember from topographic anatomy that we have triangles, that we have general arteries and nerves, and of course we have the fat layers. Fat layers, what's the function of the fat? They localize the arteries and vessels, I mean, and the nerves. And the fat has like a protection for these thin structures. You remember, yes please, you remember the anatomy. How many spaces you remember by topographic in maxillofacial region? We have two layers, superficial layers and the deepest layers. What's the main difference between the spaces? If we have superficial position, we can see it. No chair.
لا والله سيب
لا هي بتدي ساعة ونص وتمشي. بس هي بتدي ساعة ونص أو ساعة وتمشي.
غريبة غريبة أوي. أنا جبت السؤال ما أعرف
أعمل إيه طيب؟ فيديو
Наверное, может и нет. Но я запомнила, откуда я их взяла. Спасибо. And the superficials, you remember how it looks. The superficial's position, it doesn't mean that the all space is covered by the fat and by the skin. What does it mean deep? It's uncontrolled, deepest position, and you remember the symptoms of inflammation. Tuber, rubber, color, dollar, function, laser. Pain, function, change the color, hyperemia and edema. If spaces superficially, from which symptom inflammation start? Yes. Next. Edema. Next.
Fluctuation.
It will be the finally of these two. Then change the temperature. You remember hyperemia, we touch the skin with hyperemia, with focus of inflammation, you feel the change of the temperature, like normally. Then hyperemia, edema, change the temperature, pain, and change the function. This start and patients see the changes extraordinarily. Understand what I mean? Because for this we need time, 3, 5, 7, 14 days for fluctuation. Then 7 days, change the function. If it's a deepest spacers, patient never see this symptom and feel only pain and change the function. What does it mean, change the function? Patient cannot open the mouth, cannot use the hard food. You cannot, the patient cannot see it if it's deeper position. Of course, intraorally, patient will be changes in mucous membrane, but you can see, you see it, you control the color, no. But when you see at the mirror, when you met with the friends ask, what is it? If you never see it. But if it's deepest position, first symptom will be this. And this symptom, it doesn't mean that the inflammation present more than 7 days.
مش كراسي كلها نقاط وكراسي.
Maybe do you have one more for me? If I forgot it. Why we need to understand this? For example, clinical situation. Patient removed first molar from the lower jaw 5 or 7 days ago. Normally, this area regenerates 3 to 5 days. Буду закрывать комнату после своего прихода. Кто не успел до меня, то все. На 4-м курсе я уже начала это делать. Okay, come back. If, for example, we know how the process will be, patient doesn't know how it will be because it was, for example, first meeting with the dentist, with extraction. How to control it? It's impossible. It's impossible to live with each person, with each your patients. But why we need to recommend the patient situation and explain why we recommend this for the first 3 days, that for the last 5 days, that the patient understood how the process will be. If the time bigger than normally, it will be like the first rings about that it's not normally there. Sometimes it's under your control, unfortunately, because you see the patient with the exacerbation of chronic periodontitis, with cyst and with the abscess and phlegmons. Of course, we discuss odontogenic reason. What does it mean, odontogenic? It's the tooth who stimulates the inflammatory process, and this inflammatory process continue to the new layers, to the new areas between the muscles. You remember how easy to understand the process because we know the anatomy. I hope we know anatomy. Okay, we try. Why we separate the muscle, the abscess and phlegmons for 2 Гардероб работает. Я сейчас закончу занятие вообще. Напишу на вас на всех докладную. И пойдете разбираться в деканат. Почему вы не ходите в нормальной одежде на занятия?
الى الجاكيت عند الجاردروب تعال
Ты видел жакет Лида, ты стрикшн бьем, фиг.
Не работает? Здесь где-то есть вот это. Нет. О, есть. Perfect.
Давай.
Do you have a magic pen? No? No? I need a magic pen, you know. А это не работает. Понятно. While we discuss about the spaces, you know that we have primary inflammatory process and the secondary. What does it mean, primary? It does mean that this inflammation starts from this area and stimulates on this area. And secondary, it doesn't mean that from this area, the situation change and has the inflammation to the other. Why we separate for two layers? I mean, for the upper jaw and the lower jaw. Because the etiology, I mean, the tools, the odontogenic reason, localize for the upper and for the lower jaw. Today, you can take the chair from the 9610 room and come with the chair.
It's closed.
Yes.
It's closed.
96.
All closed.
Yes, all closed.
A last one with the phantoms. They are worse. You can take mine, no problem. Okay, and the situation changed when the first reason was in one area and the clinical situation we see to the other areas. What do you think? You know the information about it. How many areas we discussed for the lower jaw? What do you think? Lower jaw, yes. First, of course, we know about the anatomy. We have the floor of the mouth. What does it mean, floor of the mouth? It's the space who localize between the lower jaw and between the skin and between the mucous membrane under the tongue. You remember we have two floors, superficial and the deep, or one or second floor. Superficial floor or one floor or first floor, it's localized between the mucous membrane and between the muscles. Muscles, it's like the separation part between the second stage. But it's not the hard structures, it's the soft structures, and these structures has attached points for fix. I know where is fine. The table there, you can see it. Okay. If we know that it's the soft structures, and you remember which anatomical organs localized there? Two glands, I mean, lingual, sublingual and submandibular. It's four. Two from one side, two from the other side. You remember that it's covering by the fat and the skin. The same situation in mucosa. In mucosa, of course, not fat, but we have the layers of mucus and submucous membrane that this covering the space. You remember the tongue, how tongue has connection with this first floor. What do you think? If we discuss about the superficial and deep position, what will be the difference between this? Of course, we have two spaces, sublingual and submandibular. Sublingual, it's smaller than submandibular, but we have yes, two. You can see the green one is the sublingual, the yellow is submandibular. Can you see how present closure relationships between these two? Only the mylohyoid muscle. Now, superficial and deep. This is the superficial position to the mucous membrane, more superficial, but this more superficially to the skin. These two areas will be superficially and the deepest
According to
position.
the
Yes, it has the same structures because it's the superficial to the skin but deepest to the mucous membrane. This superficial to the mucous membrane but deepest to the skin. Tongue, it's the organ who control everything inside the mouth. You know it. About the touches, about the talking, about the thinking, the same about the eating. They has position. What do you think? If we have the inflammation in sublingual area, what will be from these fifth clinical situation factors or clinical situation symptoms for the first?
Change the function.
Change the function. What does it mean, change the
He
function?
can't speak.
Patient cannot speak clearly,
Limitation.
or patient has pain under the movements when the tongue under the movements.
Specific in the speech.
On this one area, what will be function?
Hyperemia, swelling here.
Patient cannot
Open the mouth.
change
The
the
direction.
head, change the direction, the head, especially if we discuss the position from horizontal to the deepest. You remember it, where is it? We have the same organs there. You remember when we discuss the maxillary or the salivary gland diseases or disorders. You remember that we have acute salidinitis, chronic salidinitis. These two salivary glands localize in the same areas, in sublingual areas and submandibular areas. What do you think? If we have acute salidinitis, it will be the same symptom.
No.
Why no?
Same.
It will
The same. But which functions was suffer?
secretion.
Secretion of the saliva. No pain when the patient changed the direction, because the position of the saliva deepest then is closer to the mylohyoid muscles there, and change the function about the salivation. What patient feel? Pain and xerostomia, dry mouth. How many days the acute salidinitis present?
What?
How many days the acute salidinitis present?
7 days. 1 week.
First 3 zeros, next purulent,
5
without
days.
therapy.
After 5 days, virulent.
Perfect. At the same time, we need to have the abscess and phlegmons there. For phlegmons bigger than 5, 7 to 10 days. But for abscess, it's the same time, like it's acute salidinitis. What will be the difference between these two diseases, abscess and acute sialadenitis?
In the gland?
Abscess, there is pus.
Abscess.
Abscess can change the pain even in the direction maybe because it's you touch the
Different
deep-
etiology.
The
In
it's
sialadenitis,
inflammation of the
no,
salivary.
no tooth who
Yes.
starts the change.
Yeah.
In abscess and phlegmons
Odontogenic.
present. How to use differential diagnosis? Why we discussed on this? Because we have the same symptom. Inflammatory process has the same. It doesn't matter where it is. The difference in etiology. Patient 100% know about what was the first symptom at the causing tooth or teeth. If we discuss the salivary gland disorders or diseases, no, you remember from anatomy it's the virus who stimuli, or what will be the next reason of sialadenitis?
Bacteria.
Bacteria and viral and trauma. That's there. No. How to diagnose?
Sialadenitis, urometry.
You find the etiology. You need to find the etiology. You ask the patient, you take the anamnesis from the patient. How many days? What was at home? What was the therapy, for example? What was the effect from this therapy? What patient can answer? The tooth was removed 10 days ago. It's first symptom, you understand that. Was dry socket never growing, the microflora going from the socket deeper to the bone and stimulates the inflammation. First local periosteitis, then abscess of phlegmons. All patient said was virus, was good, but after when finished all clinical symptoms, after the anti-inflammatory therapy, I feel that under the tongue, I feel that when I'm eating, it's not enough saliva, for example. Can you see it's different level from anamnesis? Or patient said, tooth was the pain 2 months ago, never treated. They come back after 1 month, pain symptom, never treated. I wait. That I wait 2 or 3 days and everything is okay. Second was the same, but today it's not the same situation. What do you think? What predisposing factors we have in maxillofacial region to civilize the abscess and phlegmons? Predisposing factors in maxillofacial region. It's not depend on immunity, because we are all different. My level, this one. My husband level, this one. My child, this one. We're not the same, but we have the same predisposing factors. Again, spaces with blood vessels, nerve channels, fat tissues, and odontogenic. Of course, not each odontogenic reason has stimulated the abscess and phlegmons, but we have the same clinical situation because we have the same anatomy. We have 2 hands, 2 legs, the same muscles, the point of attach these muscles will be the same, the function of organ will be the same, but not the same reaction of inflammation. Okay, you remember from the last semester about how many levels of answering from immune system we have. How many?
Systemic and local.
Systemic and local, okay, but by nature, by your nature, it depends on personality. Now we know that we have the same anatomy, and this process will be, it can touches every people, but we have some difference. What about the level of immunity?
White blood
How to
cells.
understand it?
White blood cells.
Analysis we will do.
We have local and systemic, okay. But how the body answer for inflammation? We have 3 types of reaction, normally. The name of this reaction.
Phagocytosis and cellular or
Intoxication.
Hematoxis. When the macrophages going to the focus of inflammation for what? For eating the microbe, yes, or to catch the dead cells, catch these cells and destroy it. Then function of macrophages finished, and these big cells going from the lymph nodes vessels to the lymph nodes for final elimination, for finally destroyed and elimination from the body. It's first level. Second level, as the cells protection. Second level, it's like the answer for the inflammation.
Spaces.
What happened with the blood circulation there?
Dilation.
Destroyed, normally destroyed, and if the blood vessels will be under the destroyed, the plasma going from these vessels and penetrated the space. Then it's like the nutrition for eating the microbes. But the idea why the plasma going out from the blood vessels, it's like the point, like the red point for the organism to stimulate the answer for this area. Understand it? Understand, because you remember that the blood vessels, nerves, and the artery and the veins and the nerves, it's all together, because between these we have small touches. How organism answering? How many cells will be produced to decrease the inflammation? It depends on the normal level of, again, answering for inflammation. We have 3 types. The name.
Of inflammation. Intoxication. Oxidation.
It's all consists of inflammatory reaction, but we discussed the answer of the body, and this answer depends on personality. How many types we have? 3. Remember pathophysiology.
Reactive and productive.
No. It's those 2 myelitis chronicle.
Myelitis.
Remember. Normergic, hyperergic, and hyperergic. This is 3 types of answer for inflammation. It depends on personality. Why we discuss it? Because this we have all, yes? The same spaces, the same vessels, the same odontogenic reason. But how macroorganism answer depends on this. What does it mean? For example, if you have a flu, what will be your condition? High temperature. What about your feeling? Can you work at this? Weakness. What will be your temperature level? High, how many?
More than 37.
More than 37. 38, for example. How you, if you have a flu?
Weakness and
The temperature, what will be the temperature?
39, I think.
39. Different answer. Your 39. I have the same. 39, 39 and 5. Immediately. 3 to 5 hours after. My answer, hyperergic. If you have, like you said, your answer, nomergic. But some person has 36 and 4. Absolutely impossible. Yes, it's the hyperergic. If we know the anatomy and pathogenesis of inflammatory process, it doesn't mean how microorganisms answer for inflammation. We know that the inflammatory process has this one, but now we know this one. How to diagnose, especially if the patient has systemic diseases. When the patient visits to you and discuss something, usually you understand the condition of the patient. But if the patient has deepest inflammation, you can check it only by the change the function and the pain. Of course, the temperature reaction will be 2. But how to diagnose between these 3? For example, acute periodontitis. My reaction will be this, your reaction will be this, the patient will be like this one. But abscess and phlegmons, it's not the same level of inflammation like the periostitis. It's absolutely changed the general condition. Condition change like normally. High temperature, weakness, headache, impossible to eat, patient doesn't want to eat, patient cannot working. But how to check this information from the patient to stop the inflammation at early like it's possible? If it's deepest, for example. Because patient can visit you on Monday and discuss something this not good, maybe I have a flu because I have the temperature. You see in the oral cavity, with God, see you after 5 days. After 5 days will be too late. Because if you can start to understanding this, you need to find the points. It's like the red lamps for you, like the fire, small, to understanding that this, it's not the typical process. It's not the periostitis, it's the abscess and phlegmons. If we know that this is inflammation, what about the lymph nodes? Will be lymph nodes. It will be like it was. You remember the osteomyelitis? We discussed 2 semesters about these diseases. How it was. Change the general condition, change the configuration. It's look the same like this one. The reason of odontogenic, the tooth, what will be the difference? Intraorally situation or extraoral situation. If we have superficial and this one, Of course, we can check by fluctuation. How it? You see the patient will change the configuration. For example, like this one. Not normally, look. Change the configuration. On this situation, patient cannot open the mouse. On this situation, can you see how change the configuration? Function changes. Unfortunately, if you have the more darker pigment on the skin, hyperemia, it's not looks like the hyperemia, it looks like the darker skin on this area, darker color of the skin. The same. Can you see how it looks normally? Yes? And how change the configuration of the face. Now we know that the inflammation who localized in these spaces has the name as the abscess. Is that the bigger one area? The name of this inflammation is phlegmon. Abscess and phlegmon has clinical changes, like the same changes about hyperemia, edema, change the configuration, or yes, change the configuration. You know, wait, when will be the break, you come. Pain and change the function. And of course, present, if you palpate this area, the focus of inflammation.
Doctor, phlegmon, it's classified superficial or deep?
Yes.
It's a question, it's superficial or deep?
Yes.
I'm asking you, it's superficial.
Yes,
or
I
deep?
ask. This one,
Yeah.
it will be the superficial, because it's localized in the which area? What do you think? No.
Yeah.
From?
Submandibular.
No. No.
Floor of the mouth, back up.
Sublingual and submandibular. We cannot finish of this.
Together.
We come back. We come back for this. If we discuss about sublingual, extraorally, you cannot find the changes because it's localized inside. Maybe only one symptom patient cannot close because when the patient close, the tongue has deeper position and pressure to the focus of inflammation. Of course, if we discussed submandibular, you can see the patient with because it's more superficial. And this, it's interesting because it will be superficially to the oral cavity, but deeper from extraorally. Understand what I mean?
Yeah.
And these two will be deepest and superficial from the classification because it's deepest extraorally, but superficially to the mucous membrane. And the same, it will be deepest to the mucous membrane, I mean the submandibular, but superficial to the skin. If we remember about the flow of the mouth, we have 5 anatomical areas. Sublingual, submandibular, right side, sublingual, submandibular, left side, and 1 submental. It's 4 areas in the floor of the mouth. If we have inflammation in one area, I mean, it doesn't matter, submandibular, submental, sublingual, and we have another one from this 5th area, the final diagnosis will be phlegmon of the floor of the mouth. Again. I'm not a robot, sorry. Flow of the mouse. Here. Submental. There. 2. 1 sublingual and 1 submandibular. This the same. If we see like this one, it looks like this. It's the tongue. This is the jaw. This is the... Okay, what's the bone who has touches to the muscles on this floor? Okay. Sublingual, submandibular, submental. If we have inflammation in one there, and we have the inflammation this, final diagnosis will be the phlegmon of the floor of the mouse. Maybe different, maybe this one, the same too, or it's maybe only on the submandibular areas. It will be the same diagnosis, the phlegmon of the mouse of the floor. Why very important to take the final diagnosis? Because it depends. We know 100% that we use the surgical treatment. We need to use the flap design. But if we know the final diagnosis, we understand what will be the tactic of surgical procedure. Where will be the operative access? For example, if it's one side, only first floor, sublingual area, where will be the point of access? We have two, intraoral and extraoral. If we discuss about the lower jaw, we have only one access, extraoral. This one, it will be not intraoral, it will be always extraoral. And of course, if it will be this one or lower floor with submental. What do you think? If we discuss the operative access, we remember the anatomy again because we need to understand where will be the point of flap. You can see the lower level of the jaw, yeah? We know about the access, but of course we prefer the intraoral. But if it's superficial position, it's impossible to use intraoral. We use extraoral access. What do you think? How changes the level of the skin there? Can you see how stretches the skin? You remember the muscles, you remember the skin, you remember the fat layers. If something inside, it's changed the direction. And if you cut like this one, when the edema finished, when the hyperemia finished, the level of the skin, if you cut there, the scar will be there. Understand what? Because the elasticity change, it's like this one, when it's normally change the position of the level of the operative access. Why very important palpate the lower jaw to understand where is the level, and from this we're using 2.5 centimeters deeper, and the operative access will be the same from one angle to the other angle of the jaw. How many t-shirts we need to cut? Skin, fat, then You remember the anatomy about the fascia of the neck. Parietal layers of the fascia, we cut it. Then we're using the special instrument without sharp edges, and we destroyed the muscles, not with the sharp, with the it's not the forceps, it's like the what's it, mosquito.
Like tweezers, doctor. It's like opening.
Yes, and we open it. Why we need to open it? You can see the part of the flap design. Of course, it's not the same like this one, because on that it will be from one angle to the other angle. We need to find the focus of inflammation. If fluctuation superficially, you touch, you can feel it. You can put the fingers and open on the same direction. If it's deepest, it's impossible to put. You need to understand where is it localized to open the flap, to open the space that this purulent exudation going from this space for drainage extraorally. Why it's very important? You can cut, you can separate, but when you don't find the purulent exudation, this situation change for next level with the complications. The idea of this, why we use the operative access, it's impossible to treat with conservative. Because the organism has answer like this one. We need to help the patient to open this space that is all purulent exudation, not accommodation on this area or going deeper to the next layers. Like this. Can you see how patient looks perfectly? How change the configuration of the face? Perfectly, yes?
In the orbital area.
This is the infraorbital area. We discussed today the lower jaw with the symptoms. Again, the borders. Why very important to understand the borders? We need to understand where will be the next level of inflammation. For example, floor of the mouth, sublingual. Where will be the next area? Submandibular. It will be this. It not finished with submental and going deeper to the neck. And then will be next area of inflammation, mediastinitis. And this is not the same like abscessor epidermolysis, because the patient, unfortunately, more than 75% die with the mediastinitis. We cannot save the patient, we cannot help, because it's too late. And the space where present the purulent exudation deeper inside, we open it, of course, but it's so big percent of the unsuccessful therapy. It's not unsuccessful, it's terrible therapy, because we can lost the patient. And this starts from one tooth or from extraction of the tooth. If you extract the tooth from the lower jaw, we have down situation, change of inflammation. If the upper jaw, it's shorter when it's deepest from the nerve and from the vessels channels going deeper to the brain. Maybe we cannot lose the patient, But the characteristic of the life after that will be terrible. Patient cannot working, cannot moving. It's like the cabbage. Sorry, but it's true. Why we discuss it in the maxillofacial touches? Because we treated the patient every day. And if you find the caries, but you don't want to see the abscess of phlegmons because it's not your direction, it's not your level of the working, write the letters to the normal doctor, I mean, who can treat it. Why we discuss? Of course, I work in the maxillofacial surgery department. It's terrible situation. Patient looks like this, with severe fever, with the high level of intoxication. Sometimes they only lies, not stand, not going to you by the head, by the legs. They come back with the friends or with the emergencies. And you understand that it's not for this patient maybe come tomorrow. Now it's impossible to treat it now. It's short period, very short period. It's 3 to 5 days and we can lose the patient. It's so quickly. Because sometimes you open it, you treated the patient, you give the desintoxication, high level of antibiotic therapy, antihistaminic, local drainage, local anti-inflammatory therapy, and the inflammation going deepest, and we really can lose the patient. It's so quickly.
Doctor, how we can diagnose the patient if it's this abscess or phlegmon?
Abscess and phlegmons, we have difference in clinic. If it's phlegmons, the area of inflammation is bigger than abscess, and usually phlegmon is more than one area. For example, if it's localized only from one area sublingual, it will be abscess. If it's from how many steps consists a therapy? First, hospitalization, yes. In hospitalization, what we need to take? Blood analysis, X-ray, and
history elevation.
Examination. Then operative access. From this we have final diagnosis. Final diagnosis consists of two parts: the words pad and the classified by the International Classification of Diseases. We have two codes, you know it. Then, for example, phlegmon of submandibular region, right side, and the classification by the GO8. That's one. For example, yes. Operative access. How we prepare the patient? Of course, we discussed about that it will be operated under the general anesthesia, from which operative access consists. We need to remove the causing tooth, yes, and open the space. How to plan? Intraoral, extraoral. Intraorally, something prepare the intraoral mucous membrane for operative access or not? We need only to antiseptic irrigation for clean, yes?
Yes, sure.
Extraorally, how to extraorally we preparing the area from the skin? we can use the solution. Which type of solution we use for clean? With alcohol, yes. Twice for 3 minutes. Then we planning where will be the cut. How to planning? Intraorally, we use the changers. What changers present intraorally? I mean, usually we open. Of course, we know the anatomy where we can cut, but usually we use the vestibulum for planning the cut design. If it will be from the superficial, I mean vestibulary, from the lingual side, we use the angulation of the jaw. How will be the position of the scalpel? Alveolar process, lingual side, tongue. Here, for example, the focus of inflammation. There. The mucous membrane looks like this. Understand what I mean? Change the direction. What will be the position of the scalpel? What do you think? How to cut? What will be the movement?
It depends on the area of the phlegmon eruption.
It's not depends on the area, it depends on the angulation of the jaw and
Anatomy.
which artery localized inside from lingual side. From lingual side, localized lingual nerve and the lingual artery. You remember how the artery localized, like this touches. It doesn't mean that we need to cut using that the scalpel fix the jaw. What does it mean? Not cut like this, deeper. You need to cut like this to feel the bone. Then you open it, and this all going from the flap where? Inside the oral cavity. Then you need to fix on this space drainage, no suturing, nothing, only open, then fix. Extraorally, which structures we cutting? Mucosa, submucosa layers, yes, and then open with the instrument and then fix the drainage. What about the extraorally? We have the same planning how will be the operative access. Why we need to planning this? You remember how the patient looks with edema and the skin change the direction because under the stretchers focus of inflammation inside put the space bigger than normally. When it's finished, we need that the skin has the normal position. We using like the plastic surgeon using the special space. What do you think? If the position of the skin will be like this, and I want to cut this, when it's changed, this change to and the stretchers, and the line of incision will be more visible. That's why we can use the anatomical spaces. For example, near to the of the mandibular. Why? When it's growing and scar formation forming, when it's regenerate, this it will be in the submandibular area. It will be invisible for the patient. Planning how it will be. Using the anatomical spaces. What the how it said what will be the how it said just a second, I forgot the word. requirement. What will be the requirement for the access? It will be open for the operating area. It will be enough for surgical procedure. It will be enough to observe. It will be enough to the area, to the layers where we work. It will be cosmetic finally, and it will be in the space where not touches the anatomical structures. It doesn't mean that it's no in the area of the cut, no vessels and no nerves. If we discuss the lower jaw, you remember that we have the ungulation. And we palpate on the patient lower level of the jaw, and from this lower level we need to push down 1.5 to 3 centimeters. It will be the line of operative access. What about requirements else? We cut layers by layers. What does it mean? We cut skin, then we cut the fat, then we open or cut the fascia, then we separate of the muscle and open to going deeper to the area where is focus of inflammation present. What will be finally? We need to take exudation. Exudation will be always with blood and purulent exudation. It may be more. When you open, it's like a river to your. How to clean it? Of course, you can use the section, it's no problem. Then you use the to fix the drainage. Before the fixing drainage, we can use antiseptic irrigation. Which antiseptic we can use?
Sodium hypochlorite.
Or we can use physiological solution, or natrium chloride, no water base, 65%. It's a physiological solution, you know it. We can use the water distillate. We can use the chlorhexidine, 6 or 5% of chlorhexidine.
One of them or all?
Can we use the peroxide? One of them, it doesn't matter. It to understand which solution we can use for cleaning, extraoral and intraorally. Can we use the peroxide? H2O2 for cleaning. Can we use?
Yeah. H2O2.
Can we use? Yes. Because all inflammation localized in the soft tissue. When we discuss the osteomyelitis, we don't use the peroxide for cleaning the bone. Because inside the bone, what happened? Peroxide has connection with the liquids. Which liquids? Blood, saliva, and purulent exudation. What will be after? Form. Big form. From which components consist form? As the action forms of oxygen, O3, with big negative effect. These cells penetrated, and if good works in soft tissues, but bad works in the hard structures, because these products, when the peroxide connection with the liquidity has stimulated the area of penetration of the active form of oxygen, O3, and this is without normal macrocirculation. Why we don't use it inside the bone, because if you remember the structure of the bone like a sponge, they fix inside and the area of necrosis will be bigger. Why we can use the peroxide? We can use it, it helps good, it works good, but it only good works in soft structures. If you use of peroxide, after you always use this, or this, you need to clean all products of this reaction. Then what we use? Drainage. No suturing. No. It's open for all time. Why we don't use the suture? Of course, we can use the coagulation when we open it, because some vessels from the skin cutting and will be the bleeding. We use the suture or using the coagulation of the blood vessels. But if we suture the area, it will be infection going deeper.
Yes.
And why we open it? That all exudation going to outside. Yes, this is the idea, and you can clean it. Sometimes we use the suture secondary time. What does it mean? When after open access,
The first
7 to 10
to help and heal.
days.
To help
Yes,
and heal.
but it will be secondary
Secondary flare.
area or secondary row of the sutures. It's very important to understand. It's the same, like you remember, periastitis, no suture, osteomyelitis, no suture, abscess and phlegmon, no suture. You can use this when you want to close a little bit the post-operative area when finished the active exudation.
Like
Purulent exudation, yes, like a closure. Because you remember from the other subject that how wounds healing, like this one. Then going deeper, and from the deepest, two structures has connection. If it will be extraorally, what we are afraid to forming the hard scar. Scar formation is not perfectly good, and the negative effect that it's no stretchers and the patient has limitation of the some movements. It's noising for the patient, and sometimes we use at the secondary time the plastic surgery procedure to change the scar there, yes, to decrease the tension in the tissues. Drainage, and then will be the same therapy. It doesn't matter, intraorally, extraorally, is the desintoxication as the first, second, antibacterial and antihistaminical treatment, painkillers, of course. And some scientists and some doctors want or prefer to prescribe the immunocorrugation therapy, but really it doesn't help when this present, because it's the different level. You can stimulate the immunity, but first of all we need to decrease the pathogenic microflora and stop the purulent exudation. They produce the toxicity of the microorganism. That's why first we can use this one, and the second, when we finished with desintoxication, antibacterial, antihistaminical therapy, after that, after 10 days, we can prescribe the stimulation of immunity and physiotherapy. And physiotherapy. Physiotherapy from second day after operative access. After operation, yes. The idea of physiotherapy, you remember how to answer. Stimulating the blood circulation. For how many days we prescribe desintoxication? Now we know from the first part of our lesson that is 3 to 5 days. Antibacterial, antihistaminical, 10 to 14, it depends. Painkillers, the same, usually 3 to 5. Of course, it's all medicine not in tablets, in intravenous or intramuscular injections, because patient cannot open and cannot eat. Why we use this type. And the physiotherapy from second day are thermal doses. Usually we prescribe for 3 to 5 days. What does it mean 3 to 5 days? We use it from one day. For example, Monday, Tuesday no, Thursday yes, that no, the Friday yes. It doesn't mean that it's for full will be 3 to 4. And then there, for example, after 7, 10 days, we can use secondary suture. How to understand when finished purulent exudation.
Like how to make sure it's finished? Like how to make sure that it's done?
Yes. If you can see that the wound is clean, it's not looks like the gray color, it's look like more naturally. You can see that the microcirculation is going higher than it was before. It's clean, not smell from this. You clean it and you can use the suturing. Of course, because if you see that the angulation of the operative access from one angle to the other angle, the size of operating this one. It's very important to understand where it will be possible. How to control it? We take this one, yes? In which day we can continue? We repeat it again. First day, then?
Fifth?
No, this day, Monday. What will be the next?
After it over.
3 to 4 days after, yes? Because we need 3 days for answering. Then 7 days, then usually 10 or 14. Very important these 2 days. Why?
See the broken. To see the change of the...
To wait the oxidation.
First 3 to 4 days we need to understand will be complications or no, or which type of inflammatory reaction we have, and we have the antibacterial, antihistaminical, how to patient body answer for our therapy. Why very important 7 days?
There is complication.
Yes, and
Therapy.
for how many days we need prescribe more antibacterial therapy? Because, can you see, 10, 14, 4 days not bigger, but generally 1 week or 2 weeks, it's different. Especially if we discuss that it will be intravenous or intramuscular injections. It's not from the gastrointestinal tract where it will be answered. This is the immediately. And for this, why we check?
To make sure the healing, the process of healing.
The processes of healing, and in which day patient come back to the work. Work, yes. Yes, because they usually stay at the department around 2 weeks. Sometimes, you know that we have a special list. It's like the insurance that you ill now, that the patient ill and you don't no need to go to the work. Yes, and we have 21 days for this. It's finished. If it's more, it doesn't mean that we need to use a special commission, not from only one doctor like you treated, from the doctor, from the head, from the other departments, to discuss why we treated the patient. For treatment, the patient need more time. For example, diabetes, hypertension, or something like this, and then we prolong this document, official document. Yes.
So doctor, please, if the patient has virus C or hepatitis, we will discover it with analysis.
Yes, of course.
And how we can control them?
If the patient has, for example, HIV, and we know it, we operate it immediately too, but we using 2 types of gloves, special, how said, forms.
Be careful.
Yes, and then when the situation will be better, we can change the department, because we have the department who has treated the HIV patient. And this department, the stomatologist, gynecologist, ophthalmologist, all. But they localize, they have the same department. It's one department with the doctors. It's not separate from maxillofacial surgery department, which HIV is the same, the hepatitis the same, and we treat it. When the condition is good, we can change the department for the last type of treatment. But usually they treat it, they separate in the separate ward, and it will be enough. But of course, the systemic diseases cannot help the doctor for treatment, because usually patient, of course, know about it. Because now we don't have a special structure who informed the job or the work or the university if the patient has HIV or hepatitis. It's the now under the control by the patient. Early we know this patient by surname, and the patient has the special therapy. Now it's the deal of the patient if they want to have a therapy by the systemic diseases, by infection diseases, unfortunately. Early was a special base. We know the name of this patient. Each department has we have big list of this, but now we don't know about it. Of course, why? The reason we take.
But
Yes, it's not only leukocyte and C proteins, it's about all, and can help you to understand at the first which type of therapy, in which department it will be, finally how to treat the patient. What do you think, how many hours need to express test of blood? Now we have a special, like a pregnancy test. It's the same system. It's immediately. You put the blood drop with the special solution, and then you put inside the indicator and the weight. 3 minutes. If it's the big hospitals, they need 40 minutes. They take the analysis, the blood analysis, and then we wait usually 40 minutes. Because it's the longer process in big departments. And then analyze the real situation. What do you think? Hospitalization, operative access, finish the treatment. What will be the prognosis?
successful.
Will be positive and negative.
Positive.
Positive, patient not happy, patient alive after that. Negative, it will be the same, but with the changes the function. For example, with the scar. What will be prognosis positive? We save the life. If the patient has complications, for example, scar formation, deformation of the soft structures, it will be negative for the patient, but positive for you, because you saved the life. Understand what I mean about the prognosis? Can we plan the plastic surgery in the area when forming the scar? Possible to plan it.
Possible.
We discussed the patient that it will be possible, but how many months we need to wait? How many months need by physiology that this all tissues regenerate?
From 3 to 6 months. 3 months.
3 to 6, yes. Usually we wait 3.5, 4 months. Bigger than it was, for example, the phlegmon on the floor of the mouth, yes. But if it's only one stage or only one side, then we wait usually 3.5 months. It's the time of regeneration, the soft structures, soft tissues in the area when was operative excess. What about the function for the patient?
It depends.
If was limitation of the mouth opening, how we discuss, how we explain the patient that this limitation will be about 4.5 weeks, about one and 1.5 months. Of course, the the level will be different, but it will stay because the muscles was under the purulent exudation. And was the destroying of the proteins, because the acid destroyed the proteins. Proteins is the component of the muscles. And then when you cut the scar formation too, that's why we recommend the physiotherapy after when it's finished with the special medicine for prophylaxis, the scar formation and the limitation of the mouth opening. Finally, how many days we treated the patient?
2 weeks.
2.5, 3 weeks in department, and then 1 month is about 2.5, 3 weeks at home. Patient come back to you normally after 1 month after
Operation.
yes. 1 month after operation, yes, we need to control it. Because sometimes will be scar formation, maybe the fistula formation, it depends. And then for finally regeneration, yes, we usually wait 3.5 months if it one side. About antibacterial and antihistaminical therapy. Antibacterial therapy we always prescribe from 2 different groups. It not was monotherapy by mono medicine. We prescribe, for example, penicillins and cephalosporins, or we prescribe penicillins and macrolides, or we prescribe penicillins, macrolides, and yes, for example, like this. We need to control all infection. Of course, we have a rule. When you open the area, you can see the purulent exudation. You can take it and send to the laboratory which microorganism inside. But the answer will be after 48 hours to analyze which microbes inside. It can help you to
Prescribe the right therapy.
yes, doses or one more medicine. Because it's always mixed flora. But it's not only one staphylococcus, streptococcus. If it will be bacteroids, for example, or candida, we need to prescribe another level of antibacterial therapy. It's very important. You can take this analysis about microflora after 48 hours. Yes. But for first 2 days we prescribe like always. But then when you have the analysis and then you can come back to you this information, you can change a little the type of antibacterial therapy for combination, one more usually. Question for me for today?
No question.
No question, perfect. Next week, what will be? You have the whole information about these phases. We start with controlled upper jaw and lower jaw. Yes, you have from the lecture this information. And we start with the test about the borders of the area. Each has one, for example, from upper, from the lower jaw. It's the test will be, yes, you need to answer the borders, which structures, for example, submandibular area, submandibular region. Middle, distal, upper, lower. How many borders we have and what is it? And which organs inside, for example, parotid gland, for example, submandibular gland, lingual nerve, for example. That's why.
So
it will be for 15 or 20 minutes, then we continue for the upper jaw. Because on the upper jaw, we have the same symptoms, but one more.
This test of the lower jaw. This test of the lower jaw.
Of the border of the lower jaw.